The event, the Pan-Pacific Surgical Association's 11th Triennial Congress. The place, Honolulu. The featured session in this coming hour, a 4-star panel discussion of massive upper GI bleeding. And now on Audio Digest Surgery, Volume 16, Number 22, the week of November 26, 1969, you'll sit in clinical consultation with Henry L. Bacchus of the University of Pennsylvania School of Medicine, Robert R. Linton of Harvard Medical School, Gwilym S. Ludwig of the University of Missouri School of Medicine, and John A. Schilling of the University of Oklahoma School of Medicine. As we join the panel, Dr. Bacchus, serving as panel moderator, has just introduced Dr. Ludwig, who describes for us the diagnostic value of radiology in massive upper GI bleeding. Let's listen to Dr. Ludwig.
I talked on this subject first about 1952, at which time the frequency of type X, in other words, the kind of case where no one could find the lesion prior to surgery, was about 25%. According to Dr. Welch's statistics, this may have improved up to about 85%, from 75 to 85%. So in about 20 years, we've developed some new techniques which have helped us make the diagnosis radiologically. You can't have this patient standing. You have to treat them very gently. Some time ago, I used to think that the use of the compression cone was interdicted. But anymore, I feel that if you are gentle, it's possible to use the compression cone and get some fairly effective help from that. Now, what has happened in the last few years? Well, we've developed a number of special tools. The problem of upper gastrointestinal examination is one which is difficult at fluoroscopy because of the changing appearance. Things are happening in the stomach all the time, and the problem that the radiologist has is to record in his mind what he actually sees under the fluoroscope. Well, we've developed a number of new tools in the last 10 years which have helped us in this a great deal. First, we have image amplification. This permits us to see a great deal more than was possible when we had the regular fluoroscope. This is a problem of physiology of vision. With the image amplification, the brightness of the image is enough that we can actually use our macular vision instead of using the peripheral kind of vision that we used with the regular fluoroscope. With the development of image amplification, we have had cine, and we now have television, and with television we have also the possibility of recording what happens on videotape. And with videotape, it's possible for the radiologist then to examine the patient, record what he sees on videotape, and then later run and rerun the examination so that he can evaluate and analyze difficult lesions without having to go back to the patient. In addition, we have developed a number of special techniques for examination. Of course, for many years we've used the different kinds of media, the thick barium, the thin barium for examining the esophagus for varices. Where leaking from a gastrointestinal lesion is suspected, I think barium would be a very poor choice of medium, and in this instance we can select gastrographin or 50% hypaque as an appropriate medium without danger of getting some unresorbable medium into the peritoneum. I think that gastrographin is a good medium. It is not as good a medium as barium because it doesn't give as good contrast. On the other hand, it is resorbable, it's gone. If it gets into the peritoneum, there's no permanent ill effect, and if you're using barium, then that obviously is going to be with you. It's not as good a diagnostic medium, and if I had my choice, I would use barium, excepting where there was a possibility of spill of contrast medium into the peritoneum. Now, one of the really important techniques in the examination of the gastrointestinal tract with radiology is the use of air contrast. Air contrast techniques are obviously not new. Dr. Aubrey Hampton, who was in Boston at the Children's Hospital prior to World War II, first introduced the use of the air contrast technique in the examination of the stomach, and particularly of the duodenum and the duodenal bulb. Since then, others have used air contrast techniques especially well in the colon, and just recently I attended the 12th International Congress of Radiology in Tokyo, where I saw what I thought was the ultimate use of air contrast techniques in the stomach. The Japanese have the unusual problem of a higher incidence of gastric carcinoma than we have in our country, where gastric carcinoma incidence is apparently dropping. And they have used the air contrast technique to an ultimate degree of sophistication, where they are actually able to find lesions which I think defy most of us in discovering them. And then the use of hypertonic duodenography. We have used hypertonic duodenography in our department, I think, quite effectively. It's a technique which you use in the special situation where you think that the disease is in the duodenum and where you want the very best possible technique to demonstrate it. Air contrast works very well with hypertonic duodenography. I think one of the things about using an air contrast technique is that you must use enough air to really distend the bowel so that you iron out lesions which are not lesions, but the real lesions will rarely iron out in the presence of the proper degree of distension of the intestine. Then we come to some of the contrast vascular techniques. These are mostly of recent origin. Many of them had their origin in Sweden. One of them, the splenoportography, has been very useful in demonstrating the varices in the esophagus and the upper part of the stomach. And I believe that in this meeting you have probably seen Dr. Ole Olsen's presentation of the use of selective arteriography in the demonstration of bleeding lesions in the gastrointestinal tract. I think that Dr. Olsen's work in this area is probably the finest which has been done in the world. Now, as a surgeon, what can you expect of your radiologist in the ability to do all of these techniques? I think that with the passage of time and with the assumption of greater responsibility in the teaching hospitals for the conduct of arteriographic procedures, that you will find that your younger radiologists are well trained in this area, and many of them will be able to carry out the specialized kinds of arteriographic and angiographic examinations which are important to the analysis of upper gastrointestinal bleeding. Each of us is here because of some special area of proficiency. My particular area of proficiency is in the analysis of diagnostic systems and some of the techniques which we have applied to the GI tract. We have used a mechanism of decision trees and Bayesian type of analysis with computers for diagnosing various kinds of lesions. We have used these same techniques in the analysis of gastric ulcer, and using computer techniques we have been able to make a differential diagnosis between benign and malignant gastric ulcer in about 95% of instances. I feel that these are techniques worthy of future exploration and may be quite applicable to providing some sort of an instrument to help us further in the analysis of upper GI bleeding.
Dr. Schilling, tell us about the operative procedures for the ulcer bleeder.
Indications for exploration, I think bleeding has to be stopped. And the massive continuous bleed is that person who you hasten to the operating room because they never stop. And the massive slower bleed, the continued low-grade bleed, and the rebleed. These are pretty straightforward indications. In the differential diagnosis, one has to think of different possibilities to be ruled in or out by both laboratory, medical, radiological, clinical, physical examination methodology, and they cover different types of problems that may be confused with a peptic ulcer. And I mention this because the problem in my mind surgically is not the peptic ulcer, where you actually have bleeding from the peptic ulcer. It's when you don't have it, and when you run into one of these things either on a misdiagnosis or unexpectedly. So it's what else might be the cause of this massive bleed that I think we should spend a little more time on. Now, there are certain factors that influence exploration, which may accelerate or decelerate exploration. The presence of the blood, what your state of the blood bank is. In our experience, a gastric ulcer over 60 is explored early, immediately, or as soon as they're ready to be explored. Rebleed following suture ligation, for example, is a special problem. Patient with a possibility of a ZE neoplasm is another one. For example, a patient with a long history of peptic ulcer that you might have operated on anyway. You might operate on emergently at the first sign of bleeding rather than waiting for conservative management. These, again, are matters of opinion, but they do influence each surgeon and each internist as they function as a team in the management of a massive or intermediate bleeder. These are other problems. The post-resectional bleed, the younger patient or the age of the patient. Probability of gastritis is an interesting problem. as well as the stress bleed. And in my opinion today, this type of massive bleeder is one of the most serious problems that we have in bleeding, and with high mortality rates. The problems of religious objection to blood. How do you manage these patients? Patients, for example, with other intercurrent diseases, the example of being severe emphysema. So here are examples of factors, and they're certainly not all of them, that influence our operation, when we do it, how we do it, and so on. There are basic operative procedures that are effective, and obviously leaving out the shunting procedures, which I know will be very ably discussed by Dr. Linton, and these are certainly obvious to all surgeons. But I don't think there's much question that today that the vagectomy and pyloroplasty with suture ligation of the bleeding duodenal ulcer is the method of choice, the first choice. And at least this is what we've employed. I might add that it's not totally without mortality rate. Facts are our mortality rates have stayed, I suppose, about the same. But with our older patients, intercurrent disease, other metabolic diseases, our deaths have not been from continued bleeding, but from problems of concurrent disease. And so let's turn to the problems as we might pick it up as a surgeon. And obviously there are 2 or 3 things that should be excluded. If a patient's had a prior aortic graft, this and a leak at the anastomotic site could be a problem. A nasogastric tube and esophagitis is another thing to be considered. Bleeding, clotting disorders, there are certain things that, though rare, should be considered, like an Ehlers-Danlos syndrome, a pseudoxanthoma elasticum, for example, Marfan's, hereditary telangiectasia. In other words, the things that you begin to think about when you don't find an obvious source of bleeding from an ulcer or from varices. And also hepatic trauma, hematobilium, can be a cause of massive upper bleeding. So from an operative point of view, then, we'd better start with anesthesia, an anesthetic agent which is adequate amount of oxygen, with special consideration about cardiac arrest, blood gases, central venous catheter, appropriate repletion. These are all things that happen ahead of time, because in some of our older massive bleeders, they've died before we've had a chance to be definitive of problems of anesthesia induction and arrest. I like to use a long midline incision. It can be made readily, provides adequate exposure, and it can be done rather quickly as one seeks the site of the bleeder. On exploration and opening the peritoneal cavity, you'd like to go to where the money is. In other words, more frequently than any other would be in the duodenum, so you'd palpate the duodenum. And if so, a gastroduodenostomy, suture ligation, pyloroplasty, followed by a vagectomy would be, in that order, the method of management. On the other hand, if on palpation there's a gastric ulcer or a neoplasm, then your first step would be a long, adequate gastrotomy. And this should be so placed that it won't interfere with possible local resection and gastrectomy, which might require a tube type of reconstruction in the Billroth 1. So an adequate long gastrotomy, and with it we'd do a 4-quadrant biopsy, and then again we could discuss whether one would do a vagectomy and a pyloroplasty or a Billroth 1 after a gastrectomy. Our experience has been that the VNPs have rebled in the gastric ulcers, and the mortality rates are actually higher than when we've gone ahead with a definitive resection with or without a vagotomy and a Billroth 1. And again, we don't have time to debate the management of the benign versus the questionably malignant ulcer here, but this is always a problem to the surgeon. And so the quadrantral biopsy and resectional therapy manages both of these factors. Now the problem comes up is when you don't find an ulcer, but you have a hemorrhagic gastritis. Now I don't know what the answer to this is, but at least the management is at first as a long liberal gastrotomy. And I mean one that you can see from one end of the stomach to the other without undue retraction. And suture ligation, at least of bleeding points that seem to be bleeding fairly briskly if you can find them. Then with that, this extensive gastritis, what does one do? A vagectomy and a pyloroplasty may shunt blood flow away from the mucosa back into the submucosa. And my personal preference is this procedure as a first choice. After this, if there's a rebleed, then I would resort to a gastrectomy, 70 to 75 gastrectomy. And then what happens to the patient that rebleeds after this? And it does happen, and this is where our mortality rate comes from. I don't know what the answer is, but it's somewhat like the stress bleeder in the old debilitated patient. Now the problem of hiatus hernia with a bleeding peptic ulcer comes in. I think repair of the hernia usually takes care of the bleeding with a vagectomy and a pyloroplasty or suture ligation if necessary. A Mallory-Weiss syndrome So rare. In fact, I've never personally experienced or had one to deal with, but I'm sure I'd mobilize the end of the esophagus and try to visualize the points of bleeding with suture ligation. With regard to peptic ulcer, I'd say it's relatively straightforward. If you can find it with a definitive bleeder with a VNP with mortality rates which range from 15 to 20% still, but with patients dying not of their bleeding diathesis but of other ones. With regard to the stress bleeding, to gastritis, this is a problem that I don't think we can solve totally, but I would like to add that in the older patient who's been operated on, it's frequently associated with sepsis, and that with this type of bleeding, whether Dr. Bacchus will call it peptic or not, at least I think that every effort should be made to drain septic foci first, and sometimes this will control the bleeding. If it continues, a vasectomy and a pyloroplasty, again, in a worse type of patient, debilitated, many transfusions, depleted, sometimes elderly, associated with sepsis, with altered clotting mechanisms, multiple transfusions. So second and third operations are difficult, and it may require a gastrectomy. Again, with almost prohibitive mortality rates, which makes me very interested in the methods that have been employed by the military related to whole body cooling as well as local cooling. Now here the mortality rates range for gastritis in our hands 40 to 50%. Stress bleeding, and I'm not talking about the curling ulcer, but the diffuse stress bleeding, 60 to 65%. So these are problems that need a special consideration. And in conclusion, what does a surgeon do when you've gone through all of these areas and you still haven't found a cause of bleeding? This happens every so often, and it'd be serious after a massive bleed. Then you want to look at the upper small bowel, examine the liver for telangiectasies, hematobilia, question of a neoplasm in the liver, obviously a Coker maneuver to examine more completely the duodenum, and for duodenal diverticulum, look for telangiectasia, for polyps that you might not otherwise have looked for, and again re-look in the stomach for the shallow erosion of the gastric ulcer that will have an artery in it that's so easily missed and concealed. And all done, and you still haven't found anything, you're left with doing nothing definitive surgically, which may not be such a bad idea, doing a vasectomy and a pyloroplasty, or a blind gastrectomy. I think the blind gastrectomy today is relatively abandoned. I would probably do a VNP under these negative circumstances, and I wouldn't argue with somebody who didn't do anything. So there are many problems when you don't find the obvious bleeding duodenal ulcer. So your preoperative differential diagnosis and your complete look with an adequate exposure and good anesthesia and repletion is important.
Dr. Linton, can you tell us about the liver and bleeding?
My subject is a very select group of so-called massive bleeding from the upper gastrointestinal tract. And I will limit myself pretty much to the patient who has bleeding esophageal varices. There isn't any question that the mortality rate from massive bleeding esophageal varices is very high. In 1953, I collected 32 patients at our hospital, the Massachusetts General, and there were 23 or 72% of these died of massive bleeding alone, without surgical intervention. Ludington in 1958 from Los Angeles reported 118, even a higher rate, 88%. Baker in 1959, I believe from Chicago, in 33 reported an incidence of 60%. So there isn't any question that we do have a very high mortality rate. I think anything is better than nothing almost in regard to the treatment of such conditions. Now, in regard to the history, I think that all your history may not avail you much in making a diagnosis. It's interesting if they've had hepatitis, if they're alcoholics, but these don't necessarily mean they're bleeding from esophageal varices. They can be bleeding from gastritis, and this is one of the differential diagnoses that you must make when a patient is brought to the accident room with a history of having vomited a quart of bright red blood. On physical examination, if they're jaundiced, if they have ascites, and they have appearance of cirrhotics of their hands, spider angiomata, large spleen and a large liver, then the chances are they have bleeding esophageal varices. But again, you can't rule out gastritis as the cause of bleeding. Now, your endoscopist may be of help to you in making the diagnosis if you have a reliable endoscopist. And I think it's worthwhile resorting to one if you have one available. He must know what he's doing. It isn't always possible to do it, even with the best of endoscopists. I believe one has a perfect right to route out the radiologist even at midnight or 2 o'clock in the morning to help differentiate in diagnosis by means of a barium swallow or some radiopaque mixture to determine by such a swallow whether esophageal varices are present. And if they're not, the chances are they are not bleeding from esophageal varices. I think there's one method still better, and that's utilization of what is called the Linton balloon tube for gastroesophageal tamponade. Bleeding occurs usually from a bleeding esophageal varix within 1 or 2 centimeters of the cardioesophageal junction. You don't control the bleeding of esophageal varices by the esophageal balloon, but you control it with a huge balloon holding about 700 or 800 cc's of air, and it's an intragastric balloon. And if you pass this into the stomach, making sure it is in the stomach, of course, before you inflate it, then putting 2 pounds pressure on it, you can stop bleeding from esophageal varices almost as quick as you can snap your fingers. Which you cannot do with this type of balloon tube, and furthermore, I know of 2 patients who were suffocated because it has slipped up into the nasopharynx and nobody was there to relieve them. So it's a very valuable aid in the differential diagnosis of bleeding, and you can rule in or out, I think almost with certainty, the question of whether they are bleeding from the esophageal varices. And if you put sufficient pressure over a wide enough area, you will stop that blood leaking from the esophageal varices. I've demonstrated this on the operating table at the time of suturing the varices. It's my opinion any patient in whom you've had to use cardioesophageal tamponade to save a patient's life by passing a balloon tube, that is your clue that immediate surgery is necessary to control the bleeding. You can stop it temporarily, but then you put the tube down again when they start 2 or 3 days later, and you're behind the 8 ball. By then, they are starved, they're in very poor condition from liver disease. So I think once you put the tube down, then you've made your decision that operation is necessary if you've been able to control the bleeding. And you are pretty sure that it is esophageal varices. And this is a transthoracoesophageal suture of the esophageal varices through about the 6th or 7th interspace. And as you look at these esophageal varices, they look as if you're looking at the large internal hemorrhoids at the other end of the gastrointestinal tract. And these are whipped over with a 000 comic catgut suture. There are usually 3 columns. The incision is closed transversely, and I think this is important, rather than longitudinally. Now, the contraindications to esophageal suture is hepatic coma, deep jaundice, prolonged prothrombin time, and inability to make the diagnosis of bleeding esophageal varices. You don't want to open the chest and the esophagus if they don't have it. So it's important to make the diagnosis. Now, with balloon tamponade alone, I got these figures from the Presbyterian Hospital some years ago. 42 patients, 24 survivals, and 18 deaths, 43% deaths. And I had 41 esophageal varices with a 25% mortality rate. A little higher than one would like, but certainly definitely lower. I was able then to create some type of portacable shunt in this group of patients, so that your salvage is considerable. I would like to damn, so to speak, emergency shunts in the treatment of bleeding esophageal varices. These are the only figures I've been able to get from the statistics. But here, out of 9 patients reported by Sullivan in 56, there were 6 deaths or 65% mortality. Preston and Cripple from Chicago in 65 reported 25, 15 deaths or 60% mortality. Furthermore, the only type of shunt you can do is a direct portacable. And here is one reason I think emergency shunts, even if you could do them, are not good, because you have to do a direct portacable. And in my experience, the immediate mortality from liver failure is high, and this is the late mortality. In splenorenal, out of 47 deaths, there were 18 or 43% due to liver failure. And in the direct portacables, there were 24 deaths, 17 or 71% due to liver failure. And here is a 5 to 10 year follow-up on 99 patients who had shunt surgery done. 73 were splenorenals. At the end of 5 years, 58% were alive. At the end of 10 years, 30% were alive. Whereas with portacables, 26, 31% alive at 5 years, and 4 or 15% at 10 years. It's my opinion, without any question, the patients who have splenorenal shunts live longer happier and healthier lives. I think there is a little higher incidence of peptic ulceration after shunt surgery. I don't think it's been too well documented as yet because there's a fair number of these patients have ulcers before we do shunts on them. So it's a little difficult to, but I think it's something that you have to think about, and my experience in doing gastric surgery after shunt surgery is not too good. It's a bad, bad thing. Because it's, first of all, it's difficult to do. Perhaps it's a little easier since the portal pressure is down, but it still is a difficult operation in a patient who has had cirrhosis of the liver, portal hypertension, splenectomy, and a splenorenal shunt. And finally, I would like to say a full cooperation of an internist interested in liver disease, a radiologist, an anesthesiologist, and a surgeon interested in this type of disease is necessary to get the best results.
The conclusion of Dr. Linton's presentation also concludes this side of your reel, Doctor. On side B, the remainder of this panel discussion on massive upper gastrointestinal bleeding. Simply reverse the two reels or cassette cartridge on your tape recorder. Audio Digest Surgery, Volume 16, Number 22, continues now on Side B with a four-star panel discussion of massive upper GI bleeding, recorded in Honolulu at the Pan-Pacific Surgical Association's 11th Triennial Congress. As we rejoin the panel, Dr. Bacchus, beginning a question and answer session, has just asked Dr. Lodwick if he meant to imply in his discussion that he used hypotonic duodenography and air contrast studies of the stomach in the patient with massive bleeding.
Well, I heard that implication made this morning by...
Have you used it?
No, I have not.
Someone this morning is using hypertonic duodenography in the massive bleeder?
That's the way I understood it.
Really? It's a new thing to me.
What do you have in mind? You had the feeling that this would create...
Well, it just never even occurred to me that in a patient who's bleeding massively and who may have been in shock that we'd be going in for procedures of this magnitude. After all, the only reason why we want you people around at all is to make a diagnosis for us. We don't want you to kill our patients. What has been your experience, Dr. Lodwick, with early barium meal study in this differential diagnosis?
Well, if you're asking me if I think that the radiologist should be available for very early studies of the upper GI tract, I certainly do. I'm willing to come out any time of the night that is necessary.
Well, do you share Dr. Satsky's view that this has tremendous value in about 75% of the cases, or not?
Yes, I would say so.
Mm-hmm. We, in that backward city of Philadelphia, of course, are utilizing more and more the angiographic techniques, particularly in those patients who have had a bleeding before and there's been no cause found. And in the study this time, one is left in great doubt. And they're a little on the middle or late age. That group of people that Griffith talked about as being, what did he say, cerebral rigidity. Those of you who heard his paper. People in later life where there may be vascular bleeding. We're utilizing now more and more this technique. And so far, we've had a good deal of success with it. Have you?
We use it. We have not used it extensively yet. We have had success with it. I recommend it.
Is that in the massive upper GI bleeder? There's a difference now.
Yes, we're only talking about massive bleeders. Now, in many of our cases, it's been the second bleed. People have been in and the studies have been entirely negative. Came back, rebleed. Year later, 2 years, 5 years later. In this group, we are likely to go to angiography right away because they've already gone through their testing and it's been unsuccessful. In the old days, you may remember that we used to have a procedure, we reported this many years ago, that in the middle-aged or elderly patient who bled profusely, say in the late 60s or 70s, complete studies during, as well as you could, and after the bleeding stopped, revealed no cause of bleeding. We used to recommend to those people with the very next sign of bleeding, they report to the hospital at once to be operated upon at once, so that the surgeon would have the opportunity of operating while they're bleeding to localize the point. Because we had cases like hemorrhagic disease of the right colon, a cercioid aneurysm of the transverse colon, things of this sort that the ordinary X-ray doesn't show. And in those cases, if the surgeon has the opportunity to go in while they're bleeding. Now, we wouldn't do that anymore. That type of patient came back, they would get an angiographic study, and if our radiologists continue to be as successful as they have so far, well, it's going to pinpoint the bleeding point for the surgeon pretty often. Dr. Schilling, I was awfully interested in what you said about gastritic bleeding. Acute ulcer. hemorrhagic gastritis, your exceedingly high mortality. I don't think this is appreciated as much as it should be. And I think those who have been giving it a lot of thought would agree somewhat, although I think your figures are perhaps a little higher than some others. These patients, many of them, I guess, are young. Some of them, as you mentioned, have stress ulcers. Do some of them get this type of gastritis after taking ulcerogenic drugs like aspirin, Rowolfia, and that sort of thing? Tell us about your experience with these acute erosions, acute gastritis and hemorrhagic gastritis, because I don't think that the average physician is familiar with the seriousness.
Well, actually, our series at our university hospital is not basically a young group, and this is why I use the word stress bleeding rather than the fewer numbers of gastritis patients who are younger, and I think there's a different type. Basically, our patients, and for example, the last 1,000 procedures that we did at the University of Oklahoma, looking at the complications, there were 8 patients who bled massively, 4 of whom died from their bleed despite all efforts. Now, these were older patients. They had intercurrent disease. They had sepsis. These older patients that we've seen are not at all different from the troops in Vietnam who've had long series of complications and who also bleed and who pose a tremendous problem of control. Now, you see in your more decadent eastern cities, the drinker, the younger person with gastritis, who's a different type of patient.
Well.
And here again, our mortality rates are a little bit lower in that individual, 30, 40% in this category, whereas in our stress bleeders or the older debilitated patients, 50, 60%. And I don't know how to manage them really, except you go through a series of steps, and our first one is a VNP with a good initial result and then a rebleed. And then you're right back where you started from, but reoperated on. And I was interested in Dr. Whalen's comments that the military is employing whole-body cooling for varices with some success. As a matter of fact, I think you'd use anything that promised to stop the bleeding and tide a patient over when they're that far down the road and possibly spare an operative procedure. So in summary, our results are poor. And on the surface, the older patient who begins to bleed, it can almost be anticipated. Anti-ulcer regimes don't seem to do much good. We don't know what the cause of it is except its relationship to sepsis.
Dr. Schilling, I'm not so sure that I'm clear, even at my age, on the classification, the terms that are used. For instance, I have in front of me the statistics of Mengai, a man of great reputation, on hemorrhagic gastritis. He reports 35 patients that had vagotomies and partial resection or vagotomy and pleuroplasty. 70% of them rebled. And he had 16 who did partial gastrectomies, and 50% of them rebled, and 19 had to be reoperated. And they had 4 patients who had total gastrectomies, and none of them rebled. Now, I must say, I don't see very many patients of this severity. I suppose in my lifetime, I probably have had the stomachs in my hands of not more, perhaps, than 20 with multiple hemorrhagic gastritis that died as a result of surgery. Those days we did just partial resection, and they bled from the remainder of the stomach stump, or they bled from the duodenum, or they bled from both, and they were young people. Well, I consider that pretty rare. Now, I get the understanding now, acute ulcers and erosions and erosive gastritis is very common to the endoscopist. You go certain series, particularly in London, you'll find they're reporting that in the neighborhood of 50% or even 60% of their bleeders by endoscopic examination are bleeding from multiple erosions or gastritis. Now, that group of people, certainly you don't have the experience that Dr. Mengai is mentioning here. Could you try to clear me up on that?
Perhaps some of the medications that you internists give the patients may have something to do with it. Not just aspirin, but all the steroids and the various drugs that produce unknown iatrogenic effects. I'm not being entirely facetious. In other words, there's so much in the way of medication is given so many patients that this may have added a component. But I think in Dr. Menghi's series, as well as in our own, which is actually smaller, it's not that younger patient that we encountered 20 or 30 years ago. It's an older patient who's been kept alive by modern medicine through a series of horrendous complications, either medical or surgical. And when they begin to bleed, it carries a 50 to 60%
semi-terminal thing you're talking about, actually. We see those, of course.
All right.
I just had one day before I left home. had everything done, still bled. We see those. Tell me about central venous pressure, monitoring the bleeder.
Let me say this, that with modern instrumentation, certain things can be a guide to therapy, just like the instruments of a pilot falls back on, which the old fellows in World War I didn't use, but keep modern planes afloat. To me, central venous pressure is not so useful from a diagnostic point of view of just shock and hypotension as it's a guide to repletion. Now, we're talking about massive bleeders with massive volume repletion under the face of vasoconstriction and shunting of blood into the pulmonary circuits. And so you may have lost 3 liters of blood, but you put back 3 liters of blood acutely and you'll create pulmonary edema and hypertension. So you can overshoot in these massive repletions. And you can also be off as far as the zeroing of your central venous catheter. It can lead you into errors, but at least things are relative. And you can look at it another way, though. It simply is a catheter in a vein, which is a little bit more central than a needle in a peripheral vein. And the complications primarily relate to the length of time that it's used. Now, people are lazy, and this includes doctors and nursing staffs and convenience, and also some of the advantages that can accrue can also override, but there's a tendency to leave a catheter in a vein longer than it should be left there. And just because it's an easy route to put something into. So this is the primary source, I think, of the problems. The acute bleeder, you're talking about not more than 5 days, probably not more than a day for an acute need of a central venous catheter. It also provides access for not only pressures, but changes in pressures. So I think it should be used, but judiciously and not in long enough to produce that terrible complication of a septic central phlebitis.
I've had a couple of bad experiences with it, Doctor. That's the reason I asked the question. We have residents, you know, and we're not able to supervise things as closely as we should. And I think I should answer this one question. How many massive bleeders, first time, can be successfully managed, that means they don't die, by medical management alone? But here we get into a question of where you are. If you're in a large city metropolitan hospital with a high percentage of liver spleen disease, that sort of patient, then of course the mortality is much higher. If your series contains a lot of patients that are over age 60 and have concomitant disease, because concomitant disease is the killer in most instances in the massive bleeder. These are all things that have to be taken into consideration. I would say that in our own experience, the patients who enter the graduate hospital through the years on my service with massive bleeding, about 20% of them go to surgery. But these are not good risk patients, and there's a fair number in this group of liver disease, and there's more than an average number that have had ulcer disease for many, many years. We sort of had a reputation for getting bad cases, if you know what I mean, referred cases, so I don't think this is a good cross-section. I don't know how many ulcers bleed. I don't think anybody does. We don't know how many patients have ulcer that never go to a doctor. A great many patients have a little mild superficial duodenal ulcer attack once a year, just like a mild nasal allergy. If they don't bother, they go on a bland diet perhaps, and may stop smoking for a week or go on a vacation or go fishing or something, and it's gone until the next year. Duodenal ulcer is not always such a serious thing. There are a lot of mild cases. I don't know what percentage of duodenal ulcers bleed. We only know the ones that come to our office and go into the hospital. So that actually, I would think that perhaps if we took a cross-section of the population everywhere of the bleeding ulcers that are massive, I don't think we'd get much beyond 8 to 10% that have to go to surgery. But I'm more surgically inclined than the surgeons. I think my surgeons procrastinate more than I do. I have a very definite criteria. If I have a massive bleeder and I've localized it to the stomach or a duodenal area, and I can't control this patient's circulatory dynamics in 24 hours, I send them to surgery. I don't wait another day or 2 or 3. And our results from surgery have been very gratifying since we've been this radical. In other words, I think in the old days we tended to, let's try it another day. Pump in another 4 pints of blood, another 5 pints of blood. Pump it in faster. I don't believe in that. because the majority of patients whose bleeding does not stop on entrance to the hospital with the first 2, 3, or 4 transfusions is bleeding into a vessel. These are usually complicated ulcers, and the ones that we operate upon, and the few that go to post, usually have had a confined perforation. Maybe it's digging into the pancreas or into a sclerotic vessel. Beware of the bleeding patient who continues to have pain after the hemorrhage, because the mild massive bleeder is bleeding from a rupture of granulation tissue. And when the clot forms, the pain stops. But if bleeding is into a vessel, the pain will continue. And this is a good sign to go by. I don't mean to say you'll send every patient to a good surgeon like Dr. Schilling because the pain wasn't relieved, but you'll give them more radical medical management and watch them more closely. Dr. Linton, do you employ intravenous posterior pituitary extract or hypothermia in addition to the usual supportive measures prior to the use of the Linton tube?
No, I do not. But my medical confreres do, and it disturbs me no end to be asked to see a patient 2 or 3 days after they've been admitted with massive bleeding that they've been playing around with these various measures trying to stop the bleeding. Patients are in much worse condition. Your mortality rate is going to be much higher. You have to have enough faith that you can stop their bleeding, and certainly the best way to stop any blood vessel bleeding is to put a ligature around it. And I see no reason why the esophagus should be any different than any other place, providing you know how to sew up the esophagus after you've made your incision in it. And that of course, is the most difficult part of the operative procedure. And it should be done with non-absorbable fine silk.
Are you saying that no one ever survives by the use of posterior pituitary extract and hypothermia, that everyone with a massive esophageal bleed must have the tube and subsequent surgery? Did you say that, or did I misunderstand?
No, I did not say that. I said any patient that you have to pass a tube and produce cardioesophageal tamponade in order to save his life. It's an exsanguinating hemorrhage. The term massive is a rather difficult term to really describe. It's an exsanguinating hemorrhage, and it's the one that you have to do in order to save his life. There are many patients who bleed from esophageal varices that aren't going to bleed this severely, and many you do not even have to do a balloon tamponage on them.
Maybe that's the key then to my question. It's a question of massiveness.
Right.
If it's really massive, the tube goes down with Linton's name on it.
That's correct.
No Sang-Stecken tube. A Linton tube goes down. And after that goes down, you ligate the varices. You never do an emergency shunt. Thank God. Do you, Dr. Schilling?
On occasion, yes.
Have you ever had any success with it?
Yes. It has a high mortality rate, but so does suture ligation. I suppose Marshal Orloff, if he were here, would probably quote the best statistics for the emergency shunt. And remember that the two are different. One is for the alcoholic and the other is for the post-hepatic necrotic cirrhotic. I would like to ask Dr. Linton a question. If the balloon works well from the stomach, why doesn't he ligate the varices from the gastric side rather than the thoracic esophageal side?
Well, a good many of these patients have ascites, and I hesitate to make an incision into the abdomen because it's going to interfere with me making a good splenorenal shunt, and I think a splenorenal shunt has it all over any other type of shunt you want to make. And it's better to make it end to side, as we've been doing for many years, rather than the newer one described by Warren. But no matter how you're going to do a splenorenal shunt, you want to have a clean upper abdomen. Now you can incise the diaphragm still further and do a transgastric suture of the esophageal varices. But my method is to incise the distal centimeter or 2 at the very most of the esophagus and the proximal portion of the fundus of the stomach by dividing the hiatus of the diaphragm so that you get at the upper part of the stomach. And I insist you must carry your suturing down to include the mucosa and submucosal veins of the fundus. So it becomes almost a intragastric suture of the varices. It's not a perfect operation, but it does tide them over so that you can get them ready for a shunt, and you should wait 5 to 6 weeks. Any longer, they may bleed again, so it's best to prepare your patient for the major shunt procedure, which you can do best, I think, by this temporary type of control.
Dr. Litton, would you care to say a word or two about the so-called prophylactic shunt? Or don't you surgeons use that term anymore? What does it mean to you, and how do you employ it?
The unfortunate thing about shunt surgery, as I say it does not cure the underlying liver pathology. All you're doing is reducing the portal venous pressure. Now, just because a patient has esophageal varices doesn't mean he's going to bleed tomorrow from them. Of course, you never know when he will. But I've seen patients demonstrated in our clinic with esophageal varices for 10 years before they suddenly let loose. And you have a certain mortality rate from this type of surgery. You do, I think, some damage to the liver by shunt surgery, especially if you want to do direct portocable shunts, and especially more so if you want to do a side-to-side portocable shunt if they have a high degree of intrahepatic portal bed block. Because with that type of shunt, you'll shunt not only all the venous portal blood, but you'll also shunt most of the hepatic arterial blood through your shunt, and you'll deprive the liver of its arterial blood supply. So I think if you're going to do a direct portocable shunt, it must be an end-to-side. But even so, doing that, you're going to make the liver a sicker liver, and the patients won't live as long. And I think shunt surgery should not be done as a prophylactic measure, and those, I think, who have run a series of them have come to that conclusion also.
It's still a little debatable, though. Some of your surgical friends, I believe, don't agree.
Oh, that's right.
Yes. Well, it's pretty hard to get surgeons to agree anyway, isn't it?
I think they'll come around, though, finally.
Someone has a question here for you. What are the canalization and drainage of the thoracic duct lymph in the management of patients with portal hypertension complicated by bleeding varices? Anything in that?
Well, we ran a series at our hospital. I was not connected with it, and it's been discarded, so I should think this answers your question. It probably isn't of much value.
You made some mention about the deleterious effect of shunts on the functions of the liver. You've had a great experience with liver functions. I know you do a lot of them in these patients with portal hypertension. But you want to just comment briefly on how you utilize the liver function tests in the appraisal of the patient who may be faced with surgery for portal hypertension?
Well, we have about 5 liver function tests that we rely on, and the most important one is the total protein and an AG ratio. Any patient who has a serum albumin level below 3 grams per cent, we do not operate upon until we get it above 3 grams per cent. And that is done either by diet, if you have enough time, or the intravenous use of human albumin. And I think it reduces your mortality rate if you can, and you should get their level up above that. That's one of the troubles of doing emergency shunt. You cannot do it quickly enough if they have a low serum albumin to get it to a respectable level. Another test that I rely great on is the cephalin flocculation, or the hanger test, because patients with a 3 to 4 plus hanger test are much more critical surgical risk, according to my statistics, than those with a 1 to 2 plus. It's not absolutely reliable, but it gives you some idea that they have a relatively sicker liver than those that have a lower cephalin flocculation. Prothrombin time is also a good simple test of liver function. And if it's more than 10 to 15% above normal, then we worry about it and try to bring it back to normal, which isn't always possible with a sick liver. Then the bromsulfonine retention test, I think, is also of value, and if it's certainly more than 20% retention, they are sick livers, and you must take every precaution you can to save liver function with your surgery. The anesthesia, I think, is terribly important, and this is one thing I haven't been able to convince surgeons of, and that is that you can operate on patients with a systolic blood pressure of 50 to 60 for 3-4 hours, and I've done it as long as 13 hours without any harm to the liver, kidneys, heart, or brain. And doing it with hypotensive spinal anesthesia, you save a lot of blood, You can construct your shunt so much easier. The thing you've got to do is get an anesthesiologist who's willing to cooperate with you and use this type of anesthesia.
You didn't mention ammonia determinations in conjunction with the bromsulfonine.
Well, I think ammonia determinations are useful only when patients are bleeding, I believe. I mean, it's a measure of blood in the gastrointestinal tract as a rule. I don't have too much faith in the blood ammonia levels if it's...
Someone in your own city, surgeon, reported that any patient who has a brom of more than 15% and ammonia, I think, of over 150, surely is bleeding from cirrhosis. Do you agree with that statement?
No, I don't.
Do you want to mention his name, or shall we not go into that?
Sure, Dr. McDermott. I think it's something, and it perhaps should be added to one of your tests if you have a laboratory that can do them when you're analyzing and trying to make a differential diagnosis. It's suggestive.
But all fairness, surgeon, have you really run a series yourself?
I have not. No, I have not found the necessity of using it.
Well, in the differential diagnosis of bleeding, I think McDermott felt it was rather important. How often do you do a splenectomy when you're doing one of your shunts? How frequently?
Oh, you must do it.
It has to be done always.
Well, if you do an end aside, now if you do Dr. Warren's method from Miami, you leave the spleen in.
Leave the spleen in.
But I've told him that the reason he's trying to avoid doing my type of end-aside shunt is that it's too hard to do, and he's invented something that's even harder to do, so I can't quite see the reason for it. It may be theoretically better, but practically it's a most extremely difficult procedure in the average case.
Well, you can say now very definitely that your type of shunt on the left side leaves the liver in much better shape in a year or 2 year follow-up than the portocable shunt.
Well,
I'm convinced of that.
I would say 5 to 10 years, and I have patients going 15 years and longer now that have splenorenal shunts, and they're holding up quite well.
I've learned a lot at this meeting. I've learned a lot more. I've heard a lot about things that I don't usually get mixed up in. And this has been a great education for me. Thank you very much, gentlemen. Aloha.
And this ends this audio digest report from the Pan-Pacific Surgical Congress. We thank all participants and the Congress for cooperation in disseminating this material. The Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association, produces audio digest surgery twice each month, along with 7 other programs of tape-recorded postgraduate medical education. All material in this program is copyrighted, and further tape duplication is prohibited.